All right, good evening, everyone. Thank you for joining us for the webinar tonight, Primary or Specialty Care, where will you thrive with Elizabeth Matthews. I'll give everyone a couple minutes to log on. In the meantime, I'm going to introduce myself. I'm Rainey McNeely. I'm the Physician Engagement Specialist here at Practice Match. If you attend any of our live fair this year or you submit your CV for review online, that all comes from me. Um, I want to remind everyone tonight that this webinar is being recorded, so you'll get the recording in an email by the end of the week from me, as well as your microphones are muted and your cameras are off. So if you have any questions, make sure you put them in the Q&A chat box. Again, I'm going to have this webinar recorded, so I'll send it all to you by the end of the week. And all of your questions, just put them in the Q&A, and Elizabeth will get those answered by the end of our webinar. It looks like we have some good attendance. So Elizabeth, if you're ready, go on ahead.
Great. Okay, well, thank you everybody for attending this webinar. I'm really excited to be talking with you about primary care or specialty care, and kind of thinking about where you think your own best fit is. I have been working in cardiology for several years, but also have worked in primary care, family nurse practitioner, and an acute care nurse practitioner. So I do have some experience in a variety of settings. And I'm really excited to be talking with you tonight. As we go through the content, though, I just want to, say that every situation is unique. Everyone is unique. So, whether a particular specialty area or primary care has pros or cons is really kind of in the eye of the beholder. And sometimes you find that over the course of your career, what works or what you want in one phase of your life may be different in another phase of your life. So it's the nice thing about being an advanced practice provider is that your career can evolve over time. Where you are today does not have to be where you are in 5 years from now or 10 or 15. So just, kind of keep that in mind, that any decisions that you make, they're not necessarily permanent. You can always make adjustments. And that's actually the really nice thing about being an advanced practice provider, is that you have a lot of flexibility, not only in terms of where you would like to practice, what kind of setting, but also in terms of what you want to practice. So for tonight, some of our key objectives are, we're going to just kind of talk briefly about some of the key differences between primary care and specialty roles. Most of you probably are already practicing APPs, or you may be finishing up your training. So you're like, well, I already kind of know the difference between that. But we'll just kind of talk about it in a little bit more depth. And then some factors to consider as you're making a decision. And this applies whether you're, coming out of your training and looking at, well, where should I apply? What should I be looking to do as my first step? Or maybe you've been practicing for a couple years and you're thinking, well, would I like to make a shift or a change? What would that look like? Does that make sense for me? And then we'll talk a little bit about some, questions and general framework that you can engage as you're thinking through these different career choices. Again, your career does not necessarily have to follow just one specific straight line in one area of practice. It can definitely be more of a zigzag, if you will, and evolve over time as you get experience and as you work in different settings. So just some, just generalities about the potential paths. Now, there are some differences between nurse practitioners and physician associates in terms of the way that the training occurs. For nurse practitioners, generally speaking, you get trained in one specialty area. So you may be trained in primary care, trained in women's health or midwifery, pediatrics, psychiatry. And that is sort of your specialty, and you can add specialties or stack them on. With a physician associate, you're trained in the medical model and a little bit of everything. You do rotations across the board. So when you are looking for that first job or looking to make a change after you've been working for a while, you usually do not need to seek additional certifications, or you have a little bit more flexibility in terms of your movement. But for most APPs, as coming out of training, or once you've been trained and working in a particular area, the two major paths are whether you go into primary care or you go into specialty care. Primary care really is your family medicine or general internal medicine, adults, geriatrics, pediatrics. Women's health actually falls under primary care. The focus obviously is on longitudinal care, often health promotion, disease prevention, a lot of chronic care management of common routine issues like hypertension, diabetes, thyroid issues, sometimes a bit of acute illness management, and oftentimes primary care is outpatient, but not necessarily exclusively. Sometimes primary care providers are hired in inpatient roles, especially as it pertains to like discharge planning or management of like primary care issues, for example, in a psychiatric residential facility. So it's not exclusive to outpatient. This is more of a generality that oftentimes you're going to be working outpatient when you're in primary care. That doesn't mean that you can't be hired by a hospital. Many hospitals and big organizations have outpatient ambulatory centers, but it often does mean that you are working in a clinic type setting. For specialty care, obviously you're going to focus on like usually one specific population or system: cardiology, dermatology, orthopedics, oncology, surgery, neuro, palliative care, ICU or critical care, midwifery for the nurse practitioners. And even within those specialties, there can be subspecialties. So, for example, in cardiology, you may focus on EP, structural heart disease, heart failure, advanced heart failure. There can be many subspecialties within a specialty, and you would be surprised how specific the focus can be in specialty care. So, usually when you're going to work in specialty care, you're focused just on that particular specialty or system. These jobs tend to be a little more procedure heavy, or you may be on like a consult service. So for example, you may be on the neuro consult team and get called throughout the hospital to do consults on patients that, there's a concern about like a CT scan, or like, whether someone had a TIA, or, so you could be called to do like a consult on that, or you could be more like management on the floor, like in a cardiac care unit, where you're doing procedures on patients, doing the admissions, managing the inpatient stay, doing the A lines, and managing the discharge process as well. So in specialty care, you could be hired inpatient, either as consult service or as a inpatient APP, or you could work in specialty clinics. So for example, you could be outpatient, but working in a cardiology practice or cardiology clinic, or, GI or neuro, or you could be working in sort of a continuity clinic in a hospital setting. So for example, could be working in like a heart failure follow-up clinic. And those patients usually that were admitted for like a decompensated heart failure would end up in your clinic following their hospital stay. So as you see, there is a lot of difference between these two areas, but there's also some areas of overlap, which can make things a little bit complicated as well when it comes to credentialing and your actual specialty, which I'll get into. And this, again, really applies for nurse practitioners. PAs are fortunate in the fact that once they complete their training and receive their licensure, they are usually able to work across the board in any specialty or any setting. And they usually do not need to go back for any additional physician associate education beyond that. For nurse practitioners, though, things are changing. It used to be that if you were a family nurse practitioner or, an adult geriatric nurse practitioner, you could kind of work across the board. You could work inpatient, outpatient, specialty, primary care. And in some places, that's still the case, but things are shifting. And this is due to this consensus model that sort of governs the scope for nurse practitioners. And as a result, the reason why I bring this up is that if you are really, really, really knowing that you have your heart set on working inpatient or working in an ICU as an NP, working in critical care, or working in a high acuity specialty like heart failure, you really need to be aware that if your training is as a primary care NP, that there may be some obstacles, along the way because of the tightening regulations around scope of practice. But all is not lost. First of all, this is not the case everywhere. And second of all, if you do find that you are trained as a primary care provider and you really want to be in a high acuity setting or doing procedures, you can get additional training. You can get an additional specialty. It's not uncommon now to see a lot of FNPs with their acute care specialty as well because of that. Same thing with psychiatry. If you really want to work in mental health, it used to be as an FNP or an AG NP, you could do that, but the preference now is really for hiring a psychiatric trained nurse practitioners. So just kind of keep that in mind. And again, there's certainly nothing lost by getting that additional certification if you need it, but it is a consideration. If you're in training now as an NP, this is a consideration. So if you already know where your heart lies, it's important to make sure that your education and training are aligned with that. Again, for ICU critical care, you're really going to need the acute care or be a physician associate. There are some hospitals that will hire FNPs, especially those with strong ICU backgrounds as RNs in that role. But I do think with the changing regulations, if you know that's where you want to go, do yourself a favor and try to, get that certification in acute care. Those certifications are usually pretty quick, 3 or 4 semesters. So for primary care, just to kind of do a little bit more of a drill down, you're going to be working more on holistic, longitudinal, ongoing patient relationships. This is actually a really wonderful aspect of primary care, is that you usually are going to have your own panel of patients, and you're going to be seeing them for the majority of visits that they come in for. If they have a lot of chronic care issues, you're going to get to manage and take care of them and see them improve. It's extremely rewarding. Feels very nice to have a patient that you get to know and that gets to know you, and you develop these really nice relationships. You tend to have a broad scope of practice because anything can happen in primary care. You could be dealing with diabetes and then a thyroid issue, and then have someone come in with a flu or a very acute issue like abdominal pain. You may do some procedures in primary care like INDs. If you have a women's health component to your primary care, you may do, some, GYN type procedures in addition to pap smears and so forth. You might do some like Nexplanon like implants or different things depending on like what kind of practice you're in. If you're family practice, you may see across the lifespan, you may see a whole family, which is also very lovely. Tend to have a lot of autonomy in primary care because generally speaking, those panels are your patients. And if you are working with physicians and other APPs, while there is often a lot of nice collaboration amongst each other, the your panel is your panel, so to speak, which is very nice. The schedule, again, this really varies significantly depending on the practice. There are practices that are often open 7 days a week, but for the most part, many providers find that they are working a holiday and weekend free type setting, meaning that they, do an 8 to 4, 9 to 5, 5 days a week. There may be different schedules that are offered or things that you can negotiate, but generally speaking, that's the typical. Again, things can differ widely by practice. Some potential considerations is that, there is a huge need for primary care. And as a result of that, oftentimes primary care providers can see very high volumes. And that can be challenging, not just for a new APP, but even for an experienced APP. Sometimes one can find that they're seeing more patients, especially with like health insurance reimbursement reductions. And just more of a need. No one likes to turn patients away. So that's certainly a consideration. And again, not a reason not to do primary care, but just something to understand. Sometimes average salaries can be lower than in some of the specialties, but it's not always like an apples to apples comparison, because oftentimes primary care providers are working a day shift. And if you're in a specialty, you may have like night shifts interspersed with day shifts, or you may have holiday obligations to work. So that could factor into, the pay structure a bit. So it's not just that specialties get paid more. That's not always necessarily the case. It's just that the pay may be higher due to overtime and different type of structure for those positions. In some cases for primary care, you may be able to get RVUs, which are basically like payments for seeing over a certain number of patients on your panel. So those can be paid out to you as like sort of like bonuses, but they're calculated, and usually like you understand how the practice has arrived at those. So that can also fit into the compensation structure as well. A lot of APPs in primary care and physicians do find that administrative burdens just increase with year by year. And that's just because of a lot of prior authorizations and insurance approvals and different things that have to happen. It's something always worth asking when you're looking into a position, whether you're switching positions or getting your first position, is, what kind of administrative support do I have? Like, or if I don't have administrative support, do I have dedicated time in my week, to address things like a whole bunch of refills in my inbox and, those different things. For specialty care, the nice thing about specialty care is that you really get to focus your energies on one particular area. Whereas in primary care, you're a bit of a generalist doing a little bit of everything. In specialty care, if you're in cardiology, for the most part, you're doing cardiology. Doesn't mean that you're never going to touch upon other things. In cardiology, we do a lot of like nephrology as well, because patients in heart failure often have renal problems. So it's not that you're just doing like just the one area with these like blinders on. It's just that really you're really focusing your knowledge base on that one particular area. And that's actually sometimes kind of nice, especially when you're coming out of your training, because you're not like drinking out of the fire hose of primary care and seeing so much at once. You're more getting that sort of specialized training in one particular area. Of course, that training is extremely in depth, and that does often require a lot of additional time that you would spend in making sure that you were, that your knowledge base was at the level that you wanted, so you could be the best provider that you could be. Many times the specialty care roles are inpatient, but as I had said prior, there's a huge need for outpatient specialty APPs. You would think that, if there was a private GI office, that maybe there would just be physicians running that, but that's really not the case anymore. Now, APPs will see patients in the GI practice, they'll get them ready for their procedures, they'll follow up with them after procedures, they'll do televisits, they'll see them in the office, they may assist with procedures as well. So, the role of the APP in a specialty practice, I think, is something that's really catching on and is a really great option if you love a specialty, but you're like, I don't really want to be in the hospital. So that's something to think about. For specialty, oftentimes you may have a little more choice in your schedule. Most hospital schedules are like 12s, or they could be like 7 days on, 7 days off. Depends on the unit. Some will have like 410s in specialty clinics, depending on whether you would be assisting in procedures or assisting it in any OR or anything. The schedule may also vary. Or you could be in a specialty practice where you're doing like an 8-hour type day. It is important to note that a lot of inpatient roles do have a rotating schedule type situation, which would mean like nights and days. And some hospitals will block those nights and days, meaning you'll do like 2 months of days and then 2 months of nights, and others will kind of intersperse them. It's a question to ask, because if you're not used to working night shifts, it's a good thing to know whether how it's structured, for an APP, because it can take a little bit of an adjustment to do that. There can be higher compensation potential, as I mentioned earlier, because of some of these schedule differences that allow for either more overtime, or you get differentials for working those nights or for the holidays. So that's something to consider. And oftentimes in specialty, you do have the opportunity for procedures. So if procedures are something that you really love, then it could be a great thing to go into specialty. For procedures, you could be doing lines, you could be doing POCUS exams. I know neuro APPs who do EVDs. So there's a wide range of things that you could be doing in specialty care. And if it's something that you wish to do and to learn, then this is a great way to go, to get into it. Just always ask, though, as you're moving into a new position, like what the onboarding is for procedures, because procedures can be taught, but you do need to have practice doing them. And you need to have a lot of practice doing them so your body gets like the muscle memory. Even something like POCUS that's not invasive, just the way that you have to position your hand to do like a cardiac POCUS, it takes practice. It takes a lot of practice. I mean, I have been doing POCUS for a couple years, and I mostly just do cardiac POCUS and pulmonary, like lung scans. But even like with the cardiac ones, I always kind of mess up when I go from like the long axis to the short axis, and I have to like reset myself. So it's something where you want to make sure that you do have that practice opportunity. Something to consider. Scope of practice, though, in specialty care may be a little different, and that usually is because when you work inpatient, it's more of a like team-based model as opposed to you just having your own panel. It doesn't mean that you don't have autonomy in decision making per se, but usually you'll find that decisions are made in a team-based, and usually after a lot of input from other providers, social workers, nurses, PTs, respiratory therapists, other consults that have come in that you've called. So, you're making decisions, and you're certainly like autonomous in that regard, but it's not quite the same as being in a clinic and having your own panel, and managing that panel from start to finish. There may be call, holiday work, and rotating shifts. And you just have to keep in mind that some specialties obviously are more in demand than others. In primary care, it's just, you know, the need is there regardless, really. I think even in saturated areas in the country, primary care jobs are well available. But in specialty, you may find that some areas are a little tighter than others. Doesn't mean you can't get into it. If it's something you love, build up your knowledge and your skills as much as you can in that area. And because that passion for the area really shines through when you're in your interviews. So a lot of times people say, well, I don't know what I want to do, like I'm finishing my training, or I've been a primary care APP for a couple years, and I do like it, but now I just kind of wonder, like, am I missing out on something else? Or, I really like just managing the hypertension and cardiac issues, or the kidney issues, or the diabetes, and I'm wondering if maybe I should make a change. But like, how do I know that that's right? And the thing is that there's really no right or wrong answer in that sense, because you can. The nice thing again about being an APP is that you can, one, usually make changes, and two, sometimes you can mold the job a little bit to your own interests. But think about that interest. If you're training now, think about those rotations that just really like impacted you, where you just like felt so energized by going to clinical, as opposed to drained by going to clinical. Where did you just want to study up like after, because everything was, that you were learning was just so exciting? That's usually a good sign. And same thing if you've been practicing. If there's a certain type of thing you like treating, like I love treating cholesterol. I just love it, but other people have, they find that boring. So, what is really grabbing you? That's a great place to start. And also think about like how you want to connect with patients. Like, are you more of a kind of like treat and street provider where, you like dealing like with the acute issue and then you just want to be done? Or are you the kind of provider who wants to have that long-term relationship? Kind of teasing that apart is really helpful, because that's going to let you know like where you kind of fit, at least at this point. We always have to think about work-life balance, right? You have to, if you have children or older parents you're taking care of, personal issues, you have to obviously think about that, because your job has to fit into your life, and that may be a consideration. Again, children are not small forever. So if you really have your heart set on, doing like critical care, but doing those 12-hour shifts now doesn't make sense, or the 7 on, 7 off because of your family structure, then there's no reason why you can't work as an APP and then, do some, like trainings or conferences in critical care, and kind of like keep your your skills afloat until you can make that change. Also, weekends and holidays, for some people, that's fine. And for others, it's just not possible. Financial goals, obviously, big thing. I think I mentioned it on another slide, but something to consider is whether the organization you're going to work with is a nonprofit. Because if you have student loans, maybe you want to, be able to have those forgiven. So if you are not working with a nonprofit, that may be, more difficult. However, it could be that the salary is going to be higher with the nonprofit and you can pay off your loans faster. But these are just considerations. Geographic demand. If you really want to do a particular specialty and there's not anything available in your area, can you move? Is that feasible? For some people it is, and for others it isn't. Training and mentorship. really important to consider what's going to be available to you in a particular specialty or in a particular setting. Are you going to have access to ongoing learning? It doesn't matter whether you're doing primary care or whether you're doing, like a CT surgery position. You want to be in a place that wants you to grow as a provider in every way possible. So that means, are those training and mentoring um, aspects available in the position? Is this something that you just have to do on your own time? If you have to do them on your own time, are they at least compensated, like in CME days and CME monies? These are important things because regardless of what you do, you are going to need to train yourself up. And if you are already an experienced provider and you want to switch specialties, yes, your sort of runway is usually a little shorter because you've already had exposure in some degree to treating patients, but you want to make sure that you can get up to speed in the time frame that feels good for you. Hospital environment versus private practice. So this is something to consider because in a hospital, for the most part, and again, these are generalizations and we can always find exceptions to the rule, but in a hospital environment, it is a little more of a team-based environment. Whereas when you're working in private practice, especially in primary care, you really are a solo provider. It doesn't mean that you don't have interaction with other staff. It just means that it's a different feeling. Sometimes RNs struggle with this because they're used, like in the hospital, when you're working as an RN, you're very much used to being in sort of this like team type environment. And then when you transition to being a solo provider, maybe you're the only provider in the practice on some days. It can feel different. It doesn't mean it's a bad thing. It just means that you have to understand what kind of person you are. Are you the kind of person who is okay with working solo? Do you prefer it? Or are you the kind of person who really needs to have a lot of social component to to your work life? Um, so other things just to consider are kind of like logistical issues. Um, we do know that there are a lot of APP programs out there, and saturation of APPs is something that I think is on a lot of our minds. It doesn't mean that there are not jobs. It just means that we have to be strategic in one, making sure that we get licensed and board certified, as soon as possible, and that we get that first job sooner rather than later. Those are very important things, and that we consider where demand is. Doesn't mean that you have to take a job in primary care if you don't want a job in primary care just because that's what's available. But, something to consider is, can I take a primary care position for a bit, work, get patient experience, and then, if I know that I want to go into like endocrine or something, make a move after that. Geographic considerations related to saturation are also an issue. Doesn't mean that you can't work in a metro. Of course, you can. It just means that you have to be cognizant of what's available, and if you want to stay in a particular location, in some cases you may have fewer options. There are other areas of the country that are wide open, so it's just something to think about. Think about whether doing procedures is something really important for you. Um, Look at the experience that you have. Experienced providers usually are wanted, especially if you have 3 to 5 years. It does not mean that you cannot get a job as a new grad. You certainly can, but do certainly highlight other patient-facing experience you have. If you worked as a medical assistant before you went to physician associate school, or if you worked in, as an RN for a couple years before you went to NP school, or you did a research project. I mean, think about all of these other things that you bring to the table. If you have experience, really drill down into the experience that you have. Did you do QI projects in your place of employment? Did you do research? Did you publish articles? Did you present at conferences? Did you help increase like all of these things should somehow be on your CV in some capacity, although not too long, because I know they don't like to read anything too long. And then consider residencies. These can be open to APPs, whether you're a physician associate or NP. They can be available in primary care or specialty care. They do tend to have quite low pay, but the nice thing about residencies is that there is a lot of didactic learning that's there for you. So it's kind of like you are a resident or a fellow. Sometimes they call them fellowships. And you may spend a year, sometimes 2 years, where a large part of your work week is spent learning, which is wonderful. It's a great thing to do if you can swing it financially. It's just that sometimes the pay is not is not what you need, to live. So that's unfortunately a consideration. A lot of times when I talk with people, if they've been APP for a while, they're like, oh, well, now I've been typecast. People see me as a cardiology PA, or they see me as an endocrine NP, or they see me as a primary care PA. And I feel like they just ask me, well, why do I want to change? And I'm not, it's first of all, changing is fine. You can do it. And yes, it's true, sometimes they do kind of like initially typecast you, but just make sure in your cover letter, in your CV, you've highlighted, like if you are an APP in primary care and you want to go into endocrine, really highlight the endocrine and the diabetes work and the thyroid work and the weight loss all those things that you do in your clinic. Make that a centerpiece. Address why you want to make the change in your cover letter. So talk about the translatable skills you have. You get a lot of skills working in primary care or working in specialty and going to primary care. Like if you're doing the reverse, people will say, well, why do you want to do primary care? You've been, doing, neuro for so many years. You can explain, look, I have been doing neuro and I've, been able to work with patients post-stroke and with, vascular dementia. And, you can really highlight how your skills are going to make the situation in that clinic improved. Especially even if you have procedural skills. Like if you can do POCUS can be done in primary care. Doing abdominal POCUS, you can bill for that. That's a billable service. Maybe you don't want to like do a full echo on because that's going to be you want to have like a fully read echo, but there's no reason why you can't do like quick lung scan, quick abdominal scan, check for DVT, anything concerned. You can always send them for further testing, but these are all billable services. So you can definitely highlight the skills that you have. Use, really, sell yourself up. But it's also important to think about like, well, why do I want to make a change? Is it because my interests have really changed? Am I just feeling a little burned out? Is it that my family or personal circumstances have changed? Is it that like my student loans, they're overwhelming me? Like really think about that, because sometimes it's not that you want to change your specialty, but just that maybe there are aspects of the position that you're in at the moment that are not really meeting your needs. So it's just important to really like think about that. And again, if you're an NP, you really need to think about your scope, because if you're in primary care and you want to make a change to, like being a psych NP, it's going to be harder now because they really now want psych NP certified, board certified NPs or, PAs. If you wanted to go into critical care, you're going to probably have to get the acute care. So again, these are not major obstacles, but they are part of your thinking and planning. And then, sometimes you're not sure, and you can have a little bit of a trial. I think shadowing with APPs or MDs is a great thing to do. And if you're in school, it's usually pretty, well, I wouldn't say easy to organize these, but sometimes you can organize them a little more easy because you're not necessarily needing like a full rotation. Just going to shadow someone for a day or two can give you a lot of insight into that area of medicine. Um, Especially if it's a fellow APP, they may really be willing to take you under their wing and mentor you. Sometimes you can go into locums, volunteer, or per diem work. This is usually a good option for those APPs who already have experience because usually for locums, they want you to have experience. So you may be able to kind of like try a specialty or try primary care as a locums or as a volunteer just to kind of see how it feels. If you don't have experience, usually locums is not the best fit just because you don't get a lot of training when you go into those situations, but you may be able to volunteer, especially if there's a network. Per diem can also be a little challenging if you're new to practice, primarily because, again, the training aspect isn't there. It's hard to ramp up if you're not working on a regular basis. But it's not impossible. So, just, think of like, depending on where you are, shadowing is a great idea or, trying some locums work. If you already work in a primary care organization or like in a multi-specialty care practice that has a lot of specialties, sometimes that's a great way to say, hey, like I'm always sending my patients over to this GI person, like maybe they'll let me just kind of like shadow them for an afternoon. So that's a great way to just kind of, again, get a little bit of a inside scoop on that specialty. You can connect with APPs and MDs on LinkedIn, different social media, at conferences or networking events. I highly recommend these. I know it's hard sometimes to go into these big conferences and then try and strike up a conversation with someone, and you're like, oh my gosh, like this feels so awkward and embarrassing. But really do it because no one wants to go sit at a conference and like be by themselves. So that physician or that APP who's there, who's been practicing for 10 years, is just as lonely as you are. So there's nothing wrong with saying, hey, I just noticed by your name tag that, you work at such and such, I'm, so and so, and either I'm graduating or I've been working, outpatient or whatever. How do you like, and just strike up a conversation, because otherwise you end up at a conference, you're spending the whole day by yourself, and it's really, it could be a lot more fun. So definitely networking events and conferences, do not be afraid. Enforce yourself, like, make a bet with yourself. Like if I go up to 3 people today, I'm going to reward myself with, something. I really recommend also trying to attend conferences or workshops that are focused on the area that you think you want to go into. There are tons. It's not just about going to the NP conference or the PA conference. I know that they have those, and those are great. But going to the actual specialty, if you're interested in cardiology, then go to a cardiology conference. Try to connect with people there. There will be APPs there. They will not just be physicians. Specialty procedure conferences for hands-on practice are a great opportunity. There are tons of them all over the country, and some of them are geared just for APPs, but this is a great way to see if maybe doing procedures is something that you even feel comfortable with. They can teach you chest tubes, A-lines, airway management, you name it. So again, you're practicing on, uh, mannequins, except for POCUS, which usually you get to practice on live people. So just, uh, give those a try if you're thinking that this is something that you want to like just see if you like. Professional and specialty organizations, I don't know all the specialty organizations, but at least for cardiology, I'm a member of the ACC. They have a special division for APPs, but I also join the other divisions that I'm interested in, like heart failure. So, you know, these are great opportunities as well, because a lot of times there's like meetings and chapter meetings, and some of the time they're online, but because you're in a smaller group, people get to know you. And then if you can get involved in these organizations early, they're great ways to make connections. Even if you already have a job or you are a new grad and you know you're going to have something lined up, great way to make connections, because you never know when you're going to want to make that next pivot. Job fairs are also a great way to learn about positions. So Practice Match has a lot of job fairs, and there are others too. But one, you can mingle with the other people there who are also attending the job fair, just to kind of understand their experience and where they've been. But talking to the recruiters is a great way too, because they often know a lot about the jobs. They know a lot about the culture, a lot about the training. They know the jobs. It's a great way to understand more about the positions is also to talk to these individuals. So again, I know it can feel a little awkward, but they want to talk to people. No one wants to go to a job fair as a vendor and sit at a booth and have no one come up to them. I'm pretty sure that they would like to have a lot of people come up to them. So go up to them. And if you're in school, take advantage of every single opportunity for your rotations. I know it can be exhausting, but if you have an option for extra rotations or rotations in an area that you think you're interested in, do them. Do extra. I know, again, I believe me, I know it's very, very, very challenging. You have to study, you may have family, but that is your time to be able to try things out with no pressure. And it's very, very, very valuable. And also to be able to see things from a bird's eye view. So I really recommend, don't shortchange your rotations. Don't just do the minimum. If there's opportunities for extra, do it. And you can build a lot of connections in your rotations. Even if you're not going to work at that hospital or that clinic, having references, having people who, when they hear of a job, call you, it's a great, great, great way to, stay connected in the field. So just a couple closing thoughts. I know this was a long presentation, but just remember, there's no one size fits all. Negotiating that first role and any subsequent roles, very, very, very important. Sometimes you can adjust things in your role. Now, again, this usually works a little better once you are coming to the role with some experience. But if there's something you really want to do, like if you're in primary care, but you really want to do like INDs and like, as many procedures as you can, make that known. Because if you want to do that stuff and there's training available and kind of say, hey, like, I want to do that, they'll ensure that you have the training. If you want to do QI projects and research and you want to work in a specialty, let them know, because my experience has been that they are dying. These hospitals are dying for people who want to do research and write papers and that kind of thing. And if yes, your major role is going to be clinical, but if you say, hey, I'm really interested in QI projects and this kind of thing, they're going to jump on that. Your career is not static. It's going to evolve as you gain experience and as your life circumstances change. And just remember that you can make a change and then you can make another change if you need to. It's okay. So don't be afraid. Don't be afraid of that. And just try to follow your interests and do what brings you professional joy, because the reason why we got into this field is because we love medicine and we love working with patients. This is our passion. So we want to be in a place that really helps us do what we love. And yeah, that's pretty much my presentation. I am going to minimize my screen so that I can answer any questions. Is that okay? Is the screen gone now? Or did I think I'm just going to stop sharing it. Sorry.
Yes, your screen's gone. We do have one question that I saw.
Yeah.
Perfect. Let me see. Can you see it on the Q&A chat
Oh,
box?
so sorry about
No,
that.
you're good. It says, I am a family nurse practitioner and currently working as a hospitalist. I've also worked in outpatient and urgent cares.
Yeah.
However, my passion is primary care, and I
Mhm.
plan to open my own telehealth practice. This question may not be relevant, but I just have to ask, do you have any input on becoming an entrepreneur in this specialty?
Yeah, no, I mean, certainly, that is another option. Obviously, usually, if you know you want to do primary care and you want to have your own practice first, obviously you need to check your state requirements because in some states, nurse practitioners have full practice authority. And in other states, they are more restricted in their practice. So, first, you need to confirm that your state enables you to be the owner of your own practice. Certainly, there is a huge need for primary care. There's a lot of different financial models that NPs can use. And this actually, for PAs too, they can, in some states, they can also practice fairly independently and can own a practice as well. Um, Again, you got to check your state regulations. Um, but just keep in mind that like being a business owner obviously is a different, is completely separate from just like being a practitioner. And there's a lot of things you need to consider how you're going to charge people, if you're going to get impaneled on insurances, if you're going to have like, backup, like another, NPPA, are you going to hire a collaborating physician, even if you don't need one because you want one? There's just a lot of different things to think about. But I certainly think that it's viable and um, can be a great way to strike out on your own, especially if you have that like entrepreneur spirit. So I would definitely encourage you to kind of check your state regulations and if you feel, you can start small, you can certainly start small. EHRs usually are not that expensive, like practice fusions, like 149 a month. Um, you can do it. Any other questions? Any other concerns about anything that I've shared?
We have
Um,
one that says, any primary care learning opportunities you recommend?
yeah, so I think that it's a great idea to keep yourself up to date because things change very rapidly in medicine, as we know. So, if you are an NP, it's often great to do the AANP conference because that covers a wide range of primary care issues and also specialty issues. So you can dabble in a little bit of everything and get your CMEs. There's also PA conferences through the PA Association. And some of them cover like different wide range of topics. I see a lot of activity on that PA association board. So that's a good place to start. And then if you have something specific, like if you want to do urgent care, like there's this like hippo boot camp training. Um, there's a Thrive APP practice training. There's lots of different opportunities that are not full on fellowships or residencies where you can just kind of like skill up a little bit or refresh yourself. The one thing I didn't address is that sometimes APPs are coming back into the workplace after having taken some time off. Maybe their family was growing or they had a personal issue and needed to take time off and then re-enter the workplace. those are great things to do to kind of show that you stayed engaged in the field while you were not actively working with patients, and can really be beneficial as you get yourself back into the work, the interviewing mode. Oh, any other questions?
Let's see, it says, I'm unsure where everyone is located. Are you hearing about significant hiring freezes for NPs and PAs?
So it's interesting. I do know that there have been some concerns about Medicaid cuts from the federal level that are impacting states. And that I think that this is kind of causing a little bit of concern amongst a lot of hospitals and major health systems that rely on that funding to provide services. I haven't heard of any widespread freezes as a result of that. But I do understand the concern. I would say that, there's not much we can do to control the political climate. And APPs have been through this before, like every couple years there's a change in guard, so to speak, and things either loosen up or tighten up, and we're still here. So I would say that don't let that be a deterrent. Certainly, there can be some hospitals that may, need to be a little tighter with hiring, but regardless, providers are still needed to take care of patients. And there are regulations around that as well. So I think we're going to be okay as a profession.
Awesome. Our next question is, if you get a chance to work in a surgical position but get accepted to a surgical fellowship at the same time, which would
Mm.
you recommend?
Oh gosh, well that's such a difficult question, because obviously if you're getting a job in the specialty that you want right off the bat, I mean, kudos to you, congratulations, that's amazing. Um, there's going to be training for sure. It would not be structured as a fellowship or residency because there is a difference. But if you feel the mentoring is going to be really strong in this surgical position, then I think it can be a great move to get that job right off the bat. However, if you feel that the training is going to be more expansive in the fellowship, like if you're going to be doing like maybe your job is going to be CT surgery, but you want to be able to have different exposures, different surgical procedures or whatever, and you feel like the training is going to be more expansive, then it may be worth going with the surgical fellowship. APPs can do a lot of procedures in surgery, like endovascular vein harvesting, like so many things. So make sure that if that's where your heart is and like you want to do it all, that you're going to be able to, be able to do it all. Or if you feel like, going for a fellowship is gonna maximize your skill set, you may want to opt for that. Fellowships do tend to pay very low. Um, but you're getting a lot of training that goes along with that, and that's a really nice thing. That's the one thing I really wish that we had as APPs as an automatic extension of our training, because when we're trained, we're expected to be fully formed providers and just go out there and do the job. um, but as we all know, no matter how great of a school we went to, we need a couple years of practice before we really feel like good about what we're doing. So, and even then, I feel like even after all these years in cardiology, I have more questions now than I did like when I started, like, a couple years ago. Um, but that's part of the growth process. So I think that weigh the pros and cons.
Awesome. Our next question says, I am an FNP BC, graduated in 2023, but recently licensed in 25 due to caring for families. I'm looking for residency opportunities in primary care and or specialties, but I'm open to relocate. But it is so costly and I'm running out of resources. What's your best advice?
Yeah, so I would say that it's not that you have to do a residency, but I understand if you feel like you're out of practice because you haven't practiced since your graduation date. I completely understand like you wanting to have a little bit more mentorship as you enter practice. I would say like if you really feel like the fellowship isn't going to work because either they're too few and far between, you'd have to move very far, or the pay is going to be too low. It is like there are some practices that really do mentor new grads very, very, very well. If you have a good mentor, another APP or a physician who really takes the time to train you, you can practice safely and you can get very, very, very good very quickly. So I would say that at the same time that you're looking for fellowships, also look for jobs. And I think that you don't need to go and apologize for taking care of your family or anything like that. You can just say, I'm recently certified and, I'm looking for primary care position. Sometimes also, like I would just say, it, if you primary care, family practice and primary care are kind of like two different things. Family practice you're going to see across the lifespan. Sometimes if you're feeling rusty, focus on the specialty in the primary care that you feel most comfortable with. So if you feel best in pediatrics, try and find a pediatrics job. If you feel best with adults, try to find a primary care job where it's adults and geriatric, because sometimes treating that whole lifespan is it's a little challenging, especially as a new grad to go from like doing a new well visit on like a 2 month old to seeing a 95-year-old who just had a stroke. So sometimes if you have a choice, it may help you get into practice a little more smoothly if you're kind of narrowing your age range a little bit.
Awesome. And then it looks like our last question says, I am a family nurse practitioner working with a hospitalist group. Would you recommend obtaining an adult gerontology acute care certification? I enjoy the schedule 7 on, 7 off versus an 8-hour shift.
I would recommend it to protect yourself for two reasons. One is from a liability perspective, because if something ever were to happen, um, from the consensus model perspective, being a hospitalist is not covered under your scope. Even if your hospital has credentialed you and allowed it, and even if the private hospital group has, hired you and everyone knows you're an FNP, your job is to protect yourself and your license and your livelihood. So that's the first reason why I would do it, is for legal liability protection. The second reason why I would do it is because I do worry that the regulations are going to continue to get tighter, and that eventually FNPs and AGNPs will not be able to work in these inpatient positions. That's not happening now, but my concern is that it is something that hospitals are already looking at. And for your own protection, it's better to be in a program, because then if anything changes, you can say, well, I'm earning my AGA CNP. I'm going to finish in a semester. Like, you'll have that under your belt. Getting that extra certification is going to be key. And then if you ever need to go and leave that position and go to another inpatient position or hospitalist position, you already have the credentials necessary, and there'll be no explaining or no, but I already have 10 years uh, do the certification. This is one reason why I did it. Again, I wasn't being pressured to do it, but I knew that I was working with high acuity patients, that it was outside of the scope of an FNP, that if something were to happen, my patient, even despite me giving the best care, that I could be liable. And I wanted to be sure that, if I needed to make a change, I would be able to with the proper scope. I know
Awesome.
that was a long presentation, but I think the slides are going to be available, so you
Yeah,
can take the time to digest some of the information and think about it, and you know, think about where you fit best.
perfect. Well, thank you so much, Elizabeth. Does anybody else have any more questions? I'm not seeing any that come in. Awesome. Well, like Elizabeth said, this was recorded, so I'll be sending that recording to everyone by the end of the week. If you have any more questions, you can feel free to reach out to me, and I can get you in contact. Thanks so much, everyone. Thanks, Elizabeth. Have a good rest of your night.
Thank you, everybody.